It's an absolute pleasure to have you join us for our 98th webinar on psychiatry. My name is Shoaib and I'm one of the co-founders of BiteMedicine, but today we are absolutely, it's an absolute pleasure to have this webinar taken by Dr. Mark Hansen, who is part of the BiteMedicine editorial body and has written some really brilliant content for us for our textbook and some of our question bank as well. So I'm going to hand over to Mark and I'll be around in the chat to try and answer some of your questions. But without further ado, I'll hand it over to you, Mark.
Thank you very much, Shoaib, and good evening, everyone. It's a pleasure to be here doing these webinars. So continuing along the theme of psychiatry, the next topic is anxiety. I'm going to dive straight in. We're starting in a similar vein, so covering the main areas, risk factors and pathophysiology. What you need to be looking out for in terms of symptoms and the many different types of anxiety disorders we're going to cover today as well as talking about the ways we can investigate and treat it. Okay, so it should, as they have been previously, lasting up to about 60 minutes. Okay, and then this is just to say that, as Shoaib mentioned, there's a large question bank on the BiteMedicine website, where you can find the most up-to-date content and hopefully very useful for your examination, so please check that out. Okay, so we'll dive straight into a case. Here presenting a 57-year-old male lawyer presenting to their GP with poor sleep and feeling tired all the time. So quite a common presentation. This chap is struggling to concentrate at work, found himself snapping at his colleagues, and he's worrying about things all the time that never used to bother him. And this has persisted on for the best part of a year, and he states he feels at a breaking point, and now he's going to see the GP. Observation-wise, he's tachycardic and slightly hypertensive, but otherwise unremarkable observations. Okay, so straight into one of our questions, and don't answer in the chat because we're going to use the Menti system again. So which of the following is a risk factor for generalized anxiety disorder? And I'm just going to take you over to the Menti system. So what you need to do, as before, is if you go to menti.com and use that code at the top there, which is 52284254, and then just answer on here. I'll give you a bit of time to do that. Okay, so just 5 or 10 more seconds there. Okay, perfect. So let's have a look. Yeah, so a real mixed bag. That's really good. So the reason I put this question is really to try and see where everyone's at in terms of their knowledge on the risk factors, because they're not always as obvious as you might think. So the right answer here actually is the overprotective parents. And I'm going to come on to explain why that is. Just a minute. So, overprotective parents, including overly harsh parents, actually is a risk factor for generalized anxiety disorder, as it causes unwarranted stress during childhood, and that is actually a trigger that may lead to anxiety later in life. In terms of the other answers why they're wrong, female is actually the risk factor for generalized anxiety disorder. There's no age group at which it's affected. It can affect you at any age, and in particular children, and we're seeing that a lot more commonly. Upcoming examination is actually a feature of situational anxiety, and that's a subtype we're going to come on to learn about later on, but it's more where you're focusing on a particular life event, and it's a temporary type of anxiety. Whereas generalized anxiety disorder is actually persisting and lasts for a longer period of time. And low socioeconomic status is actually a risk factor, and that's really to do with the greater stress and impact of having less money, and therefore you can come into more trouble later down the line in life. So we'll look at those all together. So generalized anxiety disorder is the largest group of anxiety disorders, and it's a mental health disorder characterized by disproportionate, so it's out of size really to how it should be, and that's the symptoms of anxiety. It's pervasive in that it's impacting on the patient's life. They cannot control it, uncontrollable, and it's widespread worry impacting on not just certain things but everything for them. And often they'll say they're just worrying about everything and there's nothing in particular that they're struggling with. It's actually one of the most common psychiatric disorders, and NICE groups the anxiety disorders as a whole as the most common group. And this is why it's got a global prevalence of 7.3%, which I was astounded when I read it. So I've calculated how many people that is, and it's 559,910,000 people, which is just an astonishing amount of people with anxiety. And there's a higher percentage of that in Europe. Whether that's because it's more reported or not is to be seen, but certainly it's very common in our society. And there are 600 people suffering with anxiety in England in any 1 week. So really a very common disease. So in terms of risk factors, there are a couple of non-modifiable risk factors, being female and having a family history of any mental health disorder, in particular anxiety. In terms of the modifiable risk factors, we touched a little bit on childhood trauma earlier. In particular, maltreatment, including sexual or physical abuse as a child. Parental problems we mentioned about overly protective or harsh parenting, but also included in that is the child being a witness to domestic violence, alcoholism and drug abuse in the house. And bullying and victimization among the youth is also included in there. It's a huge, broad range of traumatic experiences for the child. Environmental stresses, such as unemployment and low socioeconomic status we discussed, but things that are going to impact you massively in your life and therefore result in anxiety. Substance dependence can be co-occurring with anxiety, but also can be the cause, particularly relying on stimulants. And chronic or painful illness, and if left untreated, may result in the patient developing anxiety. Okay, so I'm just going to briefly mention the pathophysiology of it, because it's not widely known why we have anxiety, what causes it. And we're still finding out more and more about it, really. But why do we have it? It's actually a normal process to feel anxiety, particularly in childhood. We know when we're 7 to 9 months old, we're like stranger anxiety is a completely normal developing process. It's also quite useful when we're have an upcoming examination or starting a new job. It makes us more alert and more careful in what we're doing, and therefore able to do better at that task. So most of the theories around why it happens are around a state of arousal, how alert you are. And in particular, there are a few theories around the limbic system, which is why there's an image of that here. So the amygdala there in green is our memory processing area. And it also is involved in fight or flight response. The amygdala connects with the prefrontal cortex, which I'll show you here, which turns these memories and emotions into and integrates them into thinking. So clearly this area needs to be connected well. And in patients with anxiety, they've found in MRI scans, for example, that there is a disrupted brain connection in between the amygdala and the prefrontal cortex. So there may be something there that's resulting in anxiety. But they've also found that the amygdalas of patients with anxiety were actually hyperactive. And that may also be contributing to this dysregulated state of emotion. Now, the amygdala is regulated by the neurotransmitters, and we touched on neurotransmitters in Schwabe's talk on depression. The theory is that too much noradrenaline and not enough serotonin, among other neurotransmitters, are contributing to anxiety. And increased levels of noradrenaline would give you some physical symptoms, so tachycardia, tremor, sweating. Whereas low levels of serotonin will reduce your emotional stability. And contributing to that as well are low levels of GABA. So these three neurotransmitters are actually the target of a lot of treatments for anxiety, and we'll come on to those later in SSRIs, SNRIs, and pregabalin. But just before we move on, I also want to point out the hypothalamus there, and that also plays a role in anxiety and stress. When you're in a state of threat, the hypothalamus releases corticotrophin hormone, which stimulates the pituitaries to secrete ACTH, or adrenocorticotropic hormone, which will result in the adrenals producing cortisol. Now, cortisol is our stress hormone, and this is good in a state of threat, acute stress. You need levels of cortisol, but if this is happening on a regular basis, you can become in a state of chronic stress or heightened physiological state, where the patient's hypervigilance, and it's this repeated stress that then develops into anxiety. So although we're still learning a lot about it, I find the pathophysiology important because it does impact on the treatment that we're giving for our patients. Okay, so we'll just come on to another question there. I'll move us across. So moving on to diagnosis. So which of the following symptoms are not a part of the DSM-5 diagnostic criteria? And any questions you have throughout, sorry, just please put them in the chat. I'll give you a bit more time. So I'm not a fan of these negative questions, but they certainly won't ask them like that in your exams, or I hope not, but it is a good way of remembering when you have to do something like a rote learning, like a diagnostic criteria. Okay, so I'll just show that. Okay, brilliant. So the right answer here, because it's not included, is actually headaches. I'll take us back across. So yeah, 38% of you got that right. Headaches is a common physical symptom, and often people will present to the GP complaining of a headache with anxiety as the root cause. But it's actually not included in the DSM-5 diagnostic criteria, of which the other 4 are, and I'll just show you the list there. So there's the DSM-5 criteria, which tends to be used in America, and in the UK we tend to use ICD-10, and they differ slightly. NICE uses both, but predominantly DSM-5, as it is arguably slightly clearer to see. And it's worth knowing about both, and we'll touch on ICD-10 next. But let's just have a look at this here. So it's quite specific in timeline, so it's at least 6 months. So less than 6 months of symptoms, and you don't have generalized anxiety disorder. And that's important when we look at one of the subtypes later. Again, it's quite explicit in terms of the symptoms, so excessive, difficult to control, everyday issues, doesn't have to be anything specifically. And it's, there you go, disproportionate to inherent risk. So it's not in keeping with how you should be reacting to that risk. And it's resulting in impairment and distress. So importantly, they want you to exclude another mental disorder or substance misuse. Similarly with other mental disorders, you need to exclude other causes, other mental disorder causes. And then the symptoms that we were looking at least 3 of these. And it's restlessness, nervousness, easily fatigued, poor concentration, irritability, muscle tension, sleep disturbance. So relatively vague symptoms, and you'll note there's a lot of crossover with depression, but important ones to know. And here's just a table just to make that a little bit clearer. And in examinations, it's always worth writing these questions down beforehand so that you can ask specifically for these symptoms, as they may not offer them. And then moving over to the ICD-10. So again, it's generalized and persistent anxiety in any environment. They list some different symptoms, some the same. So persistent nervousness, trembling, muscle tension again, sweating, lightheadedness, palpitations. And a lot of these you can attribute to the increased levels of noradrenaline. And this expression of fear that the person or relative will shortly become ill or have an accident. Okay, so those are the 2 criteria for diagnosis of anxiety. So as I mentioned, there are many different subtypes, and as a whole, they make up the largest group of psychiatric disorders. So I'll just run through some of these for you. Panic disorder is characterized by these panic attacks, and that's a recurrent episode of sudden onset anxiety. It doesn't have to have a certain trigger, and they usually self-resolving, and they don't always last that long, sometimes minutes. And in the classification, they ask for 4 of these physical symptoms in terms of breathlessness, palpitations, nausea, fear of dying. And it's a common presentation to the emergency department in panic disorder. Social phobia is slightly different in that it's fear of a social occasion. In particular, the fear is focusing on embarrassing themselves or being scrutinized. And that fear is so great that it leads to actually avoiding the occasion altogether, which can lead to then detrimental effects on that person's life. Situational anxiety is where there's no pathological symptoms, and it's what most of us will have experienced before, where you're nervous prior to coming up to an exam, and it can be normal and actually can help you perform better. And then these four, adjustment disorder is the significant one that's different to generalized anxiety disorder in that it lasts no more than 6 months. After 6 months, it's GAD. Before then, it's adjustment disorder. And this is often related to a life stressor, such as moving house, and temporary. Obsessive compulsive disorder, or OCD, has the two main parts, the obsessive thought and the compulsive act. And it's the key start of this story is that the patient is aware that the thought is their own, but they are unable to stop the thoughts even though they want to. And also the compulsive act, they're also aware that it's coming from themselves and they don't take any pleasure in doing the acts, or they don't want to do it, and yet they still do it. And good examples of OCD often is around dirt, so repeatedly washing hands despite knowing that they're clean, to the extent that you're rubbing the skin off, and having to have things symmetrical and not enjoying the fact that they have to make it symmetrical either. Post-traumatic stress disorder is characterized by the soldier returning from the battle, and if they have these flashbacks and nightmares typically, where they relive the trauma, and it can be brought back by, for example, hearing even things like a firework could bring back the trauma of the battle, but it doesn't have to be related to that. It can be any traumatic event in life. And I've put on here medication-induced anxiety. I guess you could call that iatrogenic anxiety. And it's important to know that we're giving these patients these medications. It can result in psychiatric issues for them. In particular, patients with asthma, we're giving salbutamol, theophylline, corticosteroids in hospital, and you classically see them having like a tremor, but also stimulants like caffeine that patients take themselves. Okay, so those are the subtypes. Let's have another case. So here is a 20-year-old female university student who has come to the emergency department with palpitations, chest pain, and breathlessness, which started 30 minutes ago, and she informs you it feels like similar attacks over the last year. She's been diagnosed by her GP with a panic disorder after an unremarkable 24-hour ECG. She's quite tachycardic at 134, slightly hypertensive, and she's tachypneic, 32 rasps, and she's got saturations of 100% of normal temperature. So just another question for you guys. Okay, so you perform the arterial blood gas. What's the most likely finding? Okay, so just do it one more time. So we probably weren't expecting ABGs for psychiatry talk, but it's important in medicine that we link everything together. And hopefully you've got this two-part question. Okay, so yes, absolutely, well done. So respiratory alkalosis, and it's a common medical school question. and really important to know your common causes of abnormal ABGs. We had respiratory acidosis there. The difference being, and I've tried to write it clearly here, so I remember it, but respiratory acidosis is inadequate alveolar ventilation, as opposed to excessive. And if you imagine in a panic attack, the patient's respiratory rate was high, their oxygen saturations are high, they're taking lots of deep breaths, they're blowing off their CO2, they have high levels of oxygen. And the other options, there's not enough in the history for those to be correct. So without even seeing the ABG, you're able to come up with the answer. There are some other differentials, which would be interesting to see what people think, other than a panic disorder, which may result in respiratory alkalosis, particularly in this case. So I'll let you guys can put them in the chat, so I'll come back. So moving on to investigations, there aren't any specific investigations that you need to know for generalized anxiety disorder. There is the questionnaire, the GAD-7, which is used to assess or classify how severe the anxiety is, and that is important in terms of treatment, and we'll come on to that. So this is something that can be done in the GP surgery, and I certainly use it in specialist psychiatric wards as well, when people are getting admitted. I've written here, need to assess suicide risk if it's severe. I think it's always important to assess suicide risk in any patient presenting with a new mental health disorder. And that's to ensure that the patient is safe. You need to assess their protective factors. People actually, patients in my experience, are not offended. They actually see that you're caring for them and are happy to answer the questions. So that's important. There are some investigations you can consider with anxiety, particularly if there's anything in the past medical history that might be relevant. So I've included their full blood count, because anemia can cause fatigue, and that is one of the symptoms, or tiredness. Thyroid function tests, classically with hypothyroidism, you can get tachycardia, very similar symptoms to anxiety, palpitations. And so it's always worth checking thyroid function before diagnosing. Catecholamines in the urine, so pheochromocytoma may present with tachycardia in relation to the increased levels of noradrenaline, usually characterized by persistent hypertension. We mentioned substance misuse, so a urine drug screen is recommended, but obviously in relevance with the history. And if the patient is presenting with breathlessness, you may consider pulmonary function tests for COPD or asthma prior to diagnosing anxiety. But it's all relevant on the history for those. The GAD-7 we can touch on. This is what you may ask. It's worth knowing about it. So in the last 2 weeks, how often have you been bothered by any of the following? And what's important there, it's only asking the last 2 weeks, but you need at least 6 months of symptoms. So you're really just trying to capture how they are at this particular moment. So feeling afraid, as if something awful might happen, becoming easily annoyed or irritable, being so restless it's hard to sit still, trouble relaxing, worrying too much, not being able to stop or control worrying, feeling nervous, anxious, or on edge. So as you can imagine, it's quite easy to score quite highly. There's only 7 questions, and there's a lot of overlap. And this is how you score it. So for each section, it's either 0, 1, 2, or 3, with a maximum score then of 21. And a score of 15 or above is a severe anxiety. And we'll come on to what that means in a moment. And the moderate anxiety, 10 or above, and mild, 5. So it's all related to in the last 2 weeks, how often, and it's never had that every several days more than half of the days in the last 2 weeks, or nearly every day for the full score. Okay. So, as Shraib nicely covered, suicide and sections in his depression topic I've mentioned already. Rather than going over it again, I thought we may do some questions on it. So, this one is, hopefully you can read it at the bottom. So which patients suffering with generalized anxiety disorder are you most concerned about regarding suicide risk? So it's a little bit more to read, so I'll give you some time. Okay, last 5 seconds. Okay. Yeah, I mean, I'll be interested to see why people have chosen what they have, but there's actually no real wrong or right answer with this question. It's which are you most concerned about. I actually would be concerned about all 5 of them for different reasons. I agree with the majority of you there that the 63-year-old male living alone is the most, the one I'm most concerned about. And we'll just have a look at why. So, importantly with suicide risk, you need to assess what protective factors that person has. And that's really crucial to working out suicide risk, because again, there's no right or wrong necessarily with it. You're just calculating the risk. So the reason I've chosen this gentleman is because he has no protective factors, lives alone, and there's nothing mentioned about family and friends outside of that. He's made an attempted paracetamol overdose. And again, the reason I've chosen only 4 tablets is it's all about context and intent. So within the context of that, did that patient feel that 4 tablets was a significant amount, that it may cause death? And was their intent truly to end their life? Well, if you or I know that 2 paracetamol tablets is the normal every 4 hours, but it's probably going to take a 63-year-old male more than that in order to end his life. He doesn't necessarily know that, and so I'm concerned that he may be feeling that actually he really intended to end his life there. The other protective factors that people have, they're all related to family or religion or social support or a combination of both. And it's really important to see if you can draw those out when you're gauging suicide risk with patients. Okay. And another one on section. Okay, so which section under the Mental Health Act gives 72 hours detention power whilst the Mental Health Act assessment is arranged? So these unfortunately are black and white questions. You have to just learn the different sections. Okay. Yeah, spot on. And I think a couple of you there may have been tripped up on the different numbers, but essentially, yeah, that's absolutely right. The section 5.2 is what can be issued by any doctor with a full registration, so F2 or above. In my experience, usually by the most senior doctor, certainly probably the registrar. And that's in order to allow a mental health act assessment to be arranged, so that their patient can be properly assessed. And a mental health act assessment, does anyone know who's required for that? Because there's a certain group. The section 5.4 can actually be issued by nurses, and that gives 6-hour holding powers. And that's really just to enable the doctor to be able to come and give a 72-hour hold. Section 3 is 6 months for treatment. The 136 is what police can use to take patients from the community to a place of safety, be that a psychiatric ward or even the police cells. And section 19 is a bit of a different one, but that's issued for patients to go on leave while they're under section 3. Okay. So we'll come back to the mental health act assessment if anyone's got any ideas on that. And onto the management. All right, so there's a stepwise approach for anxiety management. Starts with the conservative measures and then moves onto medical. You can, depending on the severity, based on the GAD-7, you can start at any level. So if the patient's severe, you may just start at 4. But for all patients anyway, you try and start at 1. And as with most things, it's patient education, okay? So patient information leaflets. If the patient's informed about their disease process, they're much more likely to, 1, adhere to treatment, but 2, actually it will improve things for them just through the knowledge of what's going on. Sleep hygiene is really important. So that's regular sleeping, 8 hours a night, similar times, similar place. And exercise is really important for helping to relieve the stress that the patient may be under. So if step 1's complete and the patient's still got symptoms, you move on to step 2, which is your low intensity psychosocial interventions. And these are based on the cognitive behavioral therapy, but not actually including it, and includes things like individual self-help, psychoeducational groups. And these patients often access online themselves at their own leisure whenever they can fit it in. So if that hasn't worked, then you move on to step 3, and that's your cognitive behavioral therapy, the higher intensity, and applied relaxation. And this is really beneficial for patients. Unfortunately, in the UK, there can be long waiting lists for this, but it actually has really good evidence to suggest that it can help relieve symptoms for patients. And also step 3 is drug treatment, and we'll come on to that on the next slide. So those who are severely unwell or at risk of self-harm, suicide, self-neglect, then they require straight away step 4 and likely inpatient care. Okay. So in terms of the drug treatments, it's very similar to depression again. So the first line is selective serotonin reuptake inhibitors. And if you recall back to the pathophysiology, I mentioned that it's low levels of serotonin that may be contributing to anxiety. And therefore, we're trying to boost those levels with these medications. Sertraline is particularly good, but any SSRI can be effective. You start with a low dose and increase it up or switch to alternative at 3 to 4 weeks. And if it's not working after 2 months, then consider switching to alternative. So that's SSRIs, and the next line is SNRI. Very similar, serotonin, selective serotonin noradrenaline reuptake inhibitor, sometimes known as SSNRIs. And 2 examples are venlafaxine and duloxetine, which has crossover with peripheral neuropathy treatment as well. Now, again, it works to increase the serotonin, but also decrease the noradrenaline. And importantly here with both of these, if patients particularly are young, but anyone, they should be considered a risk of suicidal ideation and suicide within the first 4 weeks of starting this medication. So they need to be followed up regularly, at least seen within the first week, and then follow-up arranged. And then the third line is pregabalin. And I mentioned GABA in the pathophysiology as well, which is one of our inhibitory neurotransmitters. Now, pregabalin is only recommended if the first two haven't worked or are not tolerated by the patient. Benzodiazepines also work on GABA. These aren't recommended by NICE for patients to be prescribed them in primary care, and they're really just for periods of crisis and for patients to have short courses of. Okay, so we're doing well. Here's a third case for you. A 34-year-old female presents to her GP informing you that she's pregnant. She has a past medical history of generalized anxiety disorder with one previous inpatient admission for treatment, and she's established on cognitive behavioral therapy and sertraline 100. Okay, so one of the SSRIs. Observations are relatively unremarkable. So my question for you is, what's the best management option with her sertraline? So again, touching on what Shrey mentioned in SSRIs in pregnancy. In 10 more seconds or so. Okay. Yes, spot on. That's absolutely right. It's always going to be a good option in exams to discuss it with the patient first. You don't lose anything by doing that. You might avoid having to refer to a specialist if you're able to come up with a joint decision together. And also that bit of information will help them to make a decision with you. The other option, which is reasonable here, is offer a referral to a specialist. And you absolutely would do that, but first and foremost, discuss with the patient. So stopping SSRIs immediately is never recommended. You need to wean the dose gradually. And ideally, you'd, in pregnancy, ensure that they're on the lowest effective dose. Swapping to pregabalin is not recommended, as we're not really sure on the fetal safety profile for pregabalin. So it also would be contraindicated. And encourage increasing the dose of sertraline is never going to be a good option at this stage, because you're trying to do the reverse, if anything. Okay, perfect. So some of the complications of anxiety. Unfortunately, depression occurs in at least 50% of patients, and it's unclear whether the anxiety has led to depression as a result of the symptoms or the other way around, but it certainly makes it very difficult to treat this mixed picture. And substance abuse, for similar reasons, often it's a risk factor, but often people taking it to alleviate the symptoms that they're suffering as well. Other anxiety disorders are more at risk of as a result of having generalized anxiety disorder. And unfortunately, they are at increased risk of suicidal ideation and attempts. And that is why it's really important that you assess the risk when they present to you. They're also at increased risk of other comorbidities such as pain syndromes, asthma, COPD, and inflammatory bowel disease. Okay, and in terms of prognosis, it's a very complicated condition. That some people thankfully have good outcomes with treatment and will fully recover, but often a lot will remain symptomatic despite treatment, but maybe get some improvements. It's not clear as to what the pattern of the disease course is. And as I mentioned, comorbid depression, it has unfortunately the worst prognosis with more symptoms associated with it. Cognitive behavior therapy is very beneficial in anxiety and will give a great reduction in symptoms in patients, but unfortunately a lot of patients are left on waiting lists. And the study quoted by NICE, SSRIs and SNRIs are shown to be effective in 30 to 50% of patients, which is great for those patients, but unfortunately there remains a large number that are not finding benefit and may need other treatments. Okay, so that's everything I had for you guys. Just to mention the textbooks online, there's a generalized anxiety textbook, but we're constantly updating it with new content, so please check that out. And it's my first webinar. I hope it's not my last, but your feedback will be brilliant just to help me see where I can improve and make it as useful for you guys as possible. So please take the time to fill that in. And thank you very much.
Great stuff, Mark. Thanks so much for that. It was a brilliant webinar. And thank you everyone for tuning in. I've left the feedback form link in the chat, so please do fill that in for Mark. And we'll see you all at next week's webinar. Everyone have a lovely evening. Thanks again, Mark.
Thank you.